Good afternoon, good morning, or good evening for those who are joining live or remotely to this further chapter of the Reconnect webinars story. Today we are talking about refractory systemic lupus erythematosus and identification pharmacological management. This is Savino Sciascia, and I'm honored to serve as antiphospholipid syndrome group coordinator within the Reconnect family. But today, my personal and professional honor is to introduce to you all Professor Dario Loccatello, which is the Reconnect healthcare provider representative for the University Center of Excellence in Rheumatological, Nephrological, Rare Disease of the San Giovanni Bosco Hub Hospital and University of Torino. Today we will learn about how to identify, how to define, and most challenging, how to manage the most challenging and difficult to treat cases of SLE. And without much ado, it's truly my personal pleasure to introduce my teacher, my mentor, Professor Loccatello. Thank you so much.
Hello, everybody. Let me just, okay, this is my disclosure. This slide shows the treatment of the treatment algorithm of non-renal systemic lupus erythematosus. Top to bottom sequence does not imply order of preference. Methotrexate, azathioprine, and mycophenolate are equal option for the second-line therapy in mild disease or first-line therapy in moderate disease. Sorry. Okay. The use of the novel drugs, anifrolumab, as add-on therapy in severe disease refers mainly to severe skin disease. For patients with severe neuropsychiatric disease, anifrolumab as well as belimumab are not recommended yet. This is on the other hand, the induction therapy algorithm for proliferative lupus nephritis. And in this slide, the previous algorithm of 2012 was compared to the newly developed KDIGO guidelines or 2021. The main differences are colored in red. Methylprednisolone pulses were limited to 250 to 500 milligram, followed by a rapid tapering of prednisone. Hydroxychloroquine is given in any case if not contraindicated, and based on this algorithm, conventional therapy may include mycophenolate to 3 gram a day, cyclophosphamide, and the EULAR regimen is preferred to the old NIH regimen or multi-target therapy. What's of some interest is to qualify the type of therapy as regard to ethnicity. African American or Hispanics seem to respond better to mycophenolate, white European, Caucasian in general, to cyclophosphamide, Asians to the so-called multi-target therapy consisting on the combination of mycophenolate and calcineurin, sometime in the Japanese experience also cyclophosphamide. What is also to specifically addresses also that if there is an anticipated poor adherence by the patient, the induction of treatment should be given with cyclophosphamide regimen by intravenous pathway, by intravenously, and while according to different disease characteristics, for instance, the presence of glomerular crescents or refractory lupus nephritis or predominantly chronic lesions, a different type of therapy should be suggested. Standard doses for glomerular crescents, standard doses of cyclophosphamide, and are preferred. In the NIH scheme that proved to be quite effective also in very important, very severe lupus nephritis. In case of refractory lupus nephritis, B-cell depletion therapy, and when predominantly chronic lesion or on histology is present, immunosuppressive should be very minimal. Si va avanti qua. Okay. Sorry, there were some problems in the slide. With the only biological agent approved for lupus nephritis is belimumab, based on this 2-year randomized controlled trial in which belimumab was compared to placebo, to standard of care, consisting of mycophenolate and low doses of steroids. Belimumab was added to mycophenolate or cyclophosphamide followed by azathioprine. And what was achieved was that patients with proliferative lupus nephritis, class 3 and 4, could benefit from belimumab. Apparently, no benefit could be achieved in pure class 5 lupus nephritis, the membranous type of lupus nephritis, and less responses could be obtained in terms of complete renal response by combining belimumab with cyclophosphamide azathioprine, while in post-hoc analysis, the greater benefits were obtained in patients with subnephrotic range proteinuria, not in nephrotic range proteinuria. In non-renal, moderate or severe systemic lupus erythematosus, anifrolumab added to the standard of care proved to be superior to standard of care plus placebo. As regard to patients with lupus nephritis, they showed to require an intensified regimen consisting of 900 milligram as compared to 300 milligram for standard for non-renal lupus to achieve an adequate exposure and clinical efficacy. Another promising agent is in lupus nephritis is voclosporin, a novel calcineurin inhibitor that does not require blood testing and had two main characteristics: efficacious across ethnic subgroups, and with a definite trend toward efficacy in pure class 5 lupus nephritis. As regard to the B-cell depletion approach, following the failure to convincingly prove an added value of rituximab combined to standard of care in achieving more complete remission over 52 weeks, a post hoc analysis showed that achievement could be obtained, the achievement of complete peripheral depletion, as well as duration of complete depletion, were associated with complete response at 78 weeks. Some years ago, we found that a combination of 4 plus 2 doses of 335 milligrams square meter of rituximab and 2 pulses of low-dose cyclophosphamide given intravenously and corticosteroids could achieve a complete and long-lasting CD19 cell depletion. And we recently performed this case control study that compared the effectiveness of this intensive B-cell depletion regimen with a standard of care of mycophenolate or cyclophosphamide based on mycophenolate or cyclophosphamide, showing that the outcome at the 12 months was different, with better results with an intensive B-cell depletion therapy, despite the fact that it was not followed by a maintenance treatment with not only a higher rate of complete renal remission, but also lower dose of oral prednisone at 12 months. This intensive B-cell depletion therapy that had not maintenance immunosuppressive treatment, despite on the long follow-up, about 4-year follow-up, showed that the proportion of patients free of flares was greater than patients receiving standard of care. Treated patients had a 70% possibility to remain disease-free for 5 years after a single course of this intensified regimen. And this prompted us to launch this provocation. Can we change the paradigm and try to force induction therapy to make the patient free from the hostage of a prolonged maintenance immunosuppressive therapy? A non-profit randomized control trial, namely Intonate, is currently ongoing on this issue. So we can re-elaborate the algorithm of induction treatment of severe lupus nephritis, proposing, beside the new add-on top agents, an intensive B-cell depletion therapy that can be even preferable in refractory patients in relapsing diseases, besides women in childbearing age or high risk for malignancy. A plethora of new agents are under study, and among the others, a phase 3 trial with ustekinumab was prematurely discontinued for lack of efficacy. The effectiveness of tofacitinib is provided of limited data. The primary endpoint was not met with fenebrutinib, despite a strong inhibition of Bruton tyrosine kinase. Low dose of interleukin-2 resulted in clinical improvement, skin arthritis, fever, and also lupus nephritis. But they are only preliminary data, as well as the number of anti-complement drugs that are of putative interest and are still under study. Used as on the top added agents, and maybe could be used for severe lupus nephritis, and not only, but for severe systemic lupus in the future. There are classical severe life-threatening conditions that represent a challenge for clinicians. They include posterior reversible encephalopathy, cerebral venous sinus thrombosis, lupus mesenteric vasculitis, intestinal pseudo-obstruction, ureter dilation, renal thrombotic microangiopathy, diffuse alveolar hemorrhage, pulmonary arterial hypertension, and digital gangrene, and are often refractory to conventional therapy. Many attempts have been made to define refractory disease. Um, Indeed, there is no consensus definition for refractory lupus, systemic lupus erythematosus, but the term implies an inadequate or no response to the remission induction treatment. EULAR EDTA guidelines applied to lupus nephritis stated that refractory lupus is the lupus that shows failure to improve within 4 months, not achieving partial response after within 12 months, nor complete response after 2 years of treatment. An emerging opinion is that the failure to respond following treatment with both mycophenolate and the cyclophosphamide B regimen for the a long-lasting treatment of 1 year, 6 months plus 6 months, can be accepted as a definite criterion for defining a refractory lupus. However, continuing an ineffective therapy for many years, waiting for complete response, will likely result in chronic damage of the kidney, but also drug adverse effects. So, what is the approach? Sorry. So, what can be the approach for refractory or relapsing lupus? Proteasome inhibitors were used in initial study, showing a good response in terms of immunological and clinical parameters, and this experience was confirmed more recently in this small cohort of patients. Another approach is the extracorporeal treatment procedures, plasma exchange and immunoabsorption, with has been replaced plasma exchange in many countries. It's are very frequently used in the real life, especially in China. But this experience, very popular in Asia, are not supported by results from randomized controlled trial. What about stem cell transplantation? Stem cell transplantation, as reported by the EULAR registry, has been mainly used when the damage accrual was already present, and this may explain the high procedure-related mortality. But in contrast, single-center preliminary results and emerging strategies such as umbilical cord mesenchymal stem cell transplantation in the early disease course indicate a good renal outcome. But it's a restricted solution, even with these encouraging results on in terms of complete remission, kidney survival, and the overall survival. What about the novel B-cell depletion therapy? Obinutuzumab is a humanized type 2 anti-CD20 monoclonal antibody that was glyco-engineered to be able to show a greater direct cell death, reduce internalization of less reliance on complement-dependent cytotoxicity. It was used compared to placebo on the top of a standard of care based on mycophenolate, and the results were very very, very interesting. Compared to placebo, binotuzumab resulted in a greater improvement from baseline in C3, C4, and anti-DNA antibody at week 4 through week 104, with good results also in proteinuria. Rapid improvement of serological marker and slightly lower improvement in renal response could be achieved with this very interesting agent that showed in a post-hoc analysis a long-lasting B-cell depletion. Most patients in the nobility, this is the name of this trial, recovered peripheral B cells within 80 weeks. Some patients recovered very, very later. But but it seemed that the renal response at week 104 could be similar regardless of timing of the cell recovery. Recently, CD19 CAR T cells therapy was anecdotally applied in a case previously treated with mycophenolate, belimumab, cyclophosphamide, rituximab, tacrolimus, and also leukapheresis and lymphodepletion. The CD19 CAR T cell therapy may induce the rapid disappearance of antibodies anti-DNA, suggesting that CD19 expressive plasmablasts could be major sources of these antibodies. The effects of CAR T cell treatment on the activity of systemic lupus erythematosus was confirmed by the same group on a larger number of patients, with a deep depletion of cells and plasmablasts extended to tissue that could trigger to an immune reset that could allow the discontinuation of immunosuppressive therapy, which is a very important goal to try to reach. Remarkably, the role of the condition in chemotherapy should be taken into account. Patient received fludarabine 25 milligram square meter intravenously on day 5 and 4 and 3 before receiving the cells after the T cells that was engineered, and also cyclophosphamide 1 gram. So this was planned to enhance the in vivo expansion of CAR T cells. But the role of this strong immunosuppression is not quite addressed in the evaluation of this therapy. Another concern is the effect of the so-called CAR T cell associated neurotoxicity. And that is currently coined with the acronym of ICANS, immune effector cell associated neurotoxicity syndrome. That is another concern beside lymphoid malignancy, sometimes with a special target in brain. So we need some more information about this novel therapy. What about the CD38 target therapies? CD38 is highly expressed on plasma cells, but also other immune cells, important for several functions. And daratumumab, a monoclonal antibody directed at CD38, has been shown to cause depletion of plasma cells that are highly expressing this receptor. And these cells are long-lived cells residing in dedicated survival niches, unresponsive to immunosuppressive and B-cell directed therapy. We I'm trying to go ahead. Okay. We treated a small cohort of patients, and we recently published in August this year the results of daratumumab given in the scheme that you show below, 4 infusion weekly before, then each 2 weeks, and then monthly, following the general scheme for myeloma. We treated 6 patients who were definitely defined as refractory to standard and the novel agents. They have proliferative or non-proliferative lupus nephritis, apart from systemic signs. And we obtain in 5 of these patients a good decrease, a nice decrease in the proteinuria, with stabilization of serum creatinine and amelioration of C3 and C4, and a decrease in anti-DNA. Of interest, our data also suggests that daratumumab could interrupt the ongoing production of interferon that sustain the autoimmune process in systemic lupus erythematosus, increases the level of IL-10, and dramatically drop the level of serum B-cell maturation antigen that is strongly related to disease activity. Our data also showed a significant decrease in SCD 163, that is the results from the enzymatic disease of monocytes and macrophage cell membrane under inflammatory conditions. So also non-conventional parameters was dramatically modified. Notably, all these parameters were correlated to each other, and most importantly to 2K. In conclusion, daratumumab could be a robust and safer alternative to CAR T cell therapy in lupus patients who are refractory to standard of care, standard and novel B-cell depleting regimen. Thank you for your attention. Let me just thank my co-workers, rheumatologists, immunologists, and nephrologists that work together in the same division on the same patient, a unique example of multidisciplinary approach in Europe. Thank you again for your attention.
Okay, thank you so much to Professor Roccatello for this masterclass on refractory cases of SLE. I think that the talk and the webinar is now open to question, if any. Otherwise, I can start and taking the advantages of the microphone to ask to Professor Oscatello one thing. There is a long debate now, especially his most challenging case, in when and if to repeat kidney biopsy, especially when patient is not responding. What should we do in these cases?
I think that I personally think, and we experienced in the over several years, that a renal biopsy is always, in any case, less dangerous than changing immunosuppressive therapy without without profiting, without taking the advantage of looking at the features at defined in the histology findings. You can decide based on histology if the patient is still in active disease, how much is active this disease, maybe in a mixture of chronic and acute lesions, or if the urinary abnormality that you are looking at, especially proteinuria, is not induced by active lesions, but simply by chronic, definitely loss of glomeruli in the kidney. And this is the case in which not to continue immunosuppression.
Thank you. We are now trying to open the chat. Maybe I can ask to remotely to the Reconnect team to help us if there is any question in the chat, because it's so far we cannot see that.
Okay.
If not,
Hello everybody. I'm from the coordination team. I read the questions in the chat.
thank you so much.
The first was when to start treatment with the cyclophosphamide.
Cyclophosphamide it depends on the kind of lupus. In non-renal systemic lupus erythematosus, cyclophosphamide should be given in the severe cases, severe non-renal cases. In the case of lupus nephritis, cyclophosphamide is one of the initial step, together with mycophenolate or multi-target therapy agents. Cyclophosphamide, based on the more recently guidelines, should be given according to the Euler regime. That means 500 milligram given each 2 weeks for 6 times, followed by azathioprine. In the more severe lupus nephritis, the old NIH regime could be recommended for instance, in the presence of presence of very aggressive histology.
Okay, thank you very much. The second, can we combine rituximab with belimumab?
There was some attempts to combine rituximab and belimumab, especially in the sequence rituximab first, belimumab after. The best application maybe was proposed by in the Calibrate study by Dell'Era in USA from San Francisco. What Dell'Era showed in a long-lasting observation was that if you give rituximab at higher strong doses, for instance, like in the case of intensive B-cell depletion therapy I showed before, the use of belimumab after could not be necessarily useful, despite the elevation of BAFF levels. What Dell'Era showed was that given a strong B depletion and following patient with placebo or belimumab, nothing changed. The results were exactly the same over 90 weeks of observation.
Okay, thank you again. Another question on rituximab. Rituximab is chimeric. So what is the risk for anti-drug antibody in SLE?
The appearance of anti-rituximab antibodies does not necessarily mean that the drugs become ineffective. The experience are not so very common in all over the world, because very few groups usually detect anti-rituximab antibodies. We are one of these groups, and we are detecting. We have detected rituximab antibodies since many years. What we showed was that not always the presence of antibodies corresponded to any manifestation of intolerance first, and power depletion second. So the very what we have to look at to look for in the presence of chimeric antibody is the CD19 depletion was long enough to accept a second infusion despite the presence of antibodies. In any case, we can now take the advantage of the new CD and 20 anti-monoclonal antibodies, anti-CD20 antibody monoclonal antibodies to overcome any doubts as regard to rituximab.
Okay, thank you. Again, when to check serum IgG in lupus patients on B-cell depletion therapy, and when to replenish its depletion?
IgG especially, but in general immunoglobulin, are expected to slow after B-cell depletion therapy. The reduction is not so strong as we can observe in vasculitis first, because the starting levels are higher. When we have to consider that if you give immunoglobulins together with any monoclonal antibody, we force a fast metabolism of the monoclonal antibody, because we act on the Bramble receptor on the endothelial cells, favoring an enhanced destruction of and the elimination of the monoclonal antibody. On the opposite, if the level of immunoglobulins are low in the extracellular space, we expect a prolonged survival of the molecule of the monoclonal antibody. So having low level of immunoglobulin can favor a prolonged half-life of rituximab. What is the limit? The limit is conventionally established 300 milligram per deciliter. Until this level, we do not usually add immunoglobulin. And let me say that very rarely we were compelled to administer immunoglobulin in our patients.
Okay, and other 3 questions. Last on rituximab, what regimen dose of rituximab for refractory renal nephritis? Very short.
But we have observed over more than 12, almost 15 years observation in our patient that given rituximab at a dose of 375 milligram square meter 4 times plus 2 after 1 and 2 months in the so-called improved protocol, combined, especially if combined with low-dose cyclophosphamide, not for obtaining an immunosuppression, but just to synergize the effect, the depleting effect of rituximab in on B cells, we can obtain the best results in controlling even very severe case of lupus nephritis.
Another question. Thanks for the excellent presentation. When it comes to treating refractory SLE, do you think that strong anti-CD19 or anti-CD38 therapy should be as good as a CD19 CAR-T? In other words, is it just the effect of excessive B-cell plasma cell depletion, or are the extra tissue active properties of CAR-T cells essential?
CAR T cells therapy was found to be able to produce CD9 depletion and a kind of rebalancing of rebalance of the immunity. The same results we observed by looking at our at our assessment of lymphocyte assessment by cytofluorimetry by using the intensive B-cell depletion therapy. In our mind, daratumumab and in general the anti-CD38 approach should be regarded presently. Maybe in the future it can be changed, but presently should be regarded as a second step after resistance to B-cell depletion therapy. I mean, probably in some patients with lupus nephritis, but not only, some islands of plasma cells that are not reachable by rituximab or obinutuzumab or other new B-cell depleting agents can continue to produce anti-DNA antibody because in any experience the proportion of patients reaching remission, complete remission especially, independently of the kind of B-depleting agent, that does not reach 100%, never. So there is surely a small proportion of patients that can be treated after the failure of B-cell depletion therapy with anti-CD38 agents.
And another question about the use of plasma exchange in SLE-associated thrombotic microangiopathy. Can it help?
Yes, the plasma exchange treatment is a very rescue therapy. Till now, we have no proof of. It is not supported by any randomized control study. It's very difficult to perform a randomized control study with an extracorporeal procedure, of course, but we have no data that really support this approach. So plasma exchange also also based on the ASFA guidelines, the guidelines of the American Society for Apheresis, are not so much recommended in lupus, apart from extremely extreme situation. Among the other, the microangiopathy is indeed considered. So if we have no if we have no response in this patient, plasma exchange could be also considered in this case.
Okay. The last question is about CAR T cell. Is it useful only for younger people or also in older patients with lupus nephritis?
I don't think we have enough experience on this therapy to give an answer to this question. Till now, only a few cases were published. And let me say that basically it could be it could be given both to young and to old people. But let me say that what we are reading on literature on this therapy, especially from oncologic and hematologic experience, not immunologic experience, hematologic and oncologic experience. What we are reading is a strong concern. Neuropsychiatric effects long at distance from therapy should be regarded with cautiously, and cautiously also should be regarded the reports of T-cell malignancy. You have to T-cell lymphoma. You have to consider that we are engineering T-cells from the patient, giving back the patient what we have manipulated. So let me say that it's not surprising that in some cases you can induce some hematologic disorder. And until we have, when we treat oncologic patient without any other hope to be treated, maybe we can face this risk. But in lupus nephritis, even in very severe lupus nephritis, maybe the newer agents like obinutuzumab, like daratumumab, can provide a safer alternative compared to CAR T-cell approach.
And in extra time, do you think that also cost efficacy concerns must be taken into consideration when choosing to use CAR T cells?
Of course, because you need a factory that produce this manipulation of cells. So cost-effective approach, the cost-effective balance is usually negative. But let me underline. I think the most concern is not the cost, but the possible side effects at distance from the treatment. Especially considering that we have very good alternatives.
I have no questions to read in the chat.
Okay, and so I think that what we have just to do now is to thank again Professor Roccatello for this comprehensive overview, and thank you all for those of you who have been attending in person or will be attending remotely this masterclass, and a special thank to the all Reconnect webinar team, technical assistant, and all the Reconnect structure to giving all of us this opportunity to learn and discuss together, to build together with patient, physician, and all the healthcare representative a better future for patients suffering with the rheumatological disease. And I think I can thank you all, and looking forward to the next webinar. Thank you.